We are now recording, and I'd like to welcome you all to the oral capstone presentation by Lisa Gilliam, who is one of our master students in the Management and Organizational Leadership track. And Lisa, I'd like to introduce you to our panel. We have Dr. Cheryl Rules, who is the Dean of the College of Nursing and Health Professions, Ms. Pat Winberg, who is the Chair of the College of Nursing, Susan Trell, who is the lead faculty for the BSN program. And I think that is it. Anyway, I'm going to go ahead and make you host again so you can take back.
I think I am still host.
Oh, okay. Sorry.
That's
We'll
okay.
go ahead and let you get started then. Okay.
All right. Hello, everybody. Good afternoon. My name is Lisa Gilliam. And for my capstone project, I decided to do it on nurse burnout, the risk, implications, and intervention strategies post-COVID. Okay, so in this presentation, we'll be reviewing the background, our problem statement, purpose, literature review, project design, evaluations, implications, and recommendations. So the background of burnout. What is burnout? Burnout has been in existence since 1970 when psychologist Herbert Furtenberger first described burnout as a syndrome of exhaustion. According to Patton in 2019, burnout was officially identified as a syndrome by the World Health Organization, and it was classified under factors influencing health status and contact with increasing nurse shortages. Burnout has been found to affect individuals who experience large amounts of personal involvement and empathy, such as nurses. We do this every single day. And burnout is related to our increasing nurse shortage. The purpose of this presentation was to identify the level of burnout among nurses and to identify strategies that can be implemented to reverse this burnout. Our problem statement. Many of our nurses work in a very high stress environment. We're working under fast conditions. We have short staff often, and this high stress is a very big contributor to burnout. Burnout has many negative effects. It costs our organization money by increasing our nurse shortages or turnovers. And it also affects our patient satisfaction scores, which in turn affects our value-based reimbursement payments. Burnout affects our physical and mental well-being of nurses, which again leads to our poor quality patient care. And with the COVID-19, it really increased the amount of burnout felt among nurses because they were placed in stresses that they were never even thought that they would have to face, and in extreme condition working environments. So the effects of the pandemic. COVID-19 placed a tremendous amount of strain on our emotional turbulence of our nurses. This high stress left many of our nurses feeling ill themselves. They had a hard time going to work. Some are even feeling effects of post-traumatic stress disorder as we speak today. The working environments led to exhaustion, both physically and mentally. These patients or these nurses were dealing with patients who had no hope of surviving. They had no more resources that they can attempt to do to save their lives. They were left in fear of obtaining the virus themselves, of bringing it home to their families, the fear of running out of PPE. They also were forced to work in conditions that were not optimal. Wearing the full PPE gear was very hot. It was uncomfortable. It limited them from being able to take breaks as often as they needed, especially during this pandemic, because donning and doffing took so much time. And even today, they don't know what our actual, what's going to come of the pandemic and our healthcare workers, what's going to be the long-term effects. A study that was done at the beginning of the pandemic found that 67% of nurses stated that they planned to leave their current employer or the practice of nursing altogether. And in this past December of 2020, the ANA conducted a survey, and found that 75% of those nurses that they had surveyed admitted to being exhausted in the previous 2 weeks. Symptoms of burnout include emotional exhaustion, detachment, tiredness, and irritability. The exhaustion can lead to a lack of empathy. You can feel the numbness, some cynicism. There's a wide range of effects that not only affects the nurse personally, but it can affect the coworkers and it can affect our patients that can feel the effects of the burnout. The negative effects of burnout. It kind of goes in a cycle, as you can see. When we have burnout, we have a high increase of nurse turnover, and that leads to our patients, our nursing staff shortage, which then leads to job dissatisfaction and poor quality of patient care. There's also safety concerns that can happen. So this cycle just kind of goes around and around if we don't keep burnout at bay or find a way to resolve these issues. For my literature review, I used Google search engine, EBSCO, and Ovid. I looked at compassion fatigue and burnout, COVID-19 and burnout and patient safety, burnout and patient satisfaction, a theoretical framework, burnout surveys, and interventions, which I will go and let you know what I found on each of those. So burnout and compassion fatigue. Cocker and Joss explored the differences, the effectiveness of interventions to reduce compassion fatigue in the community services, emergency, and healthcare workers. Compassion fatigue is also associated with burnout. It has very similar symptoms, and it does lead up to full-blown burnout. Compassion fatigue is, the research conducted on compassion fatigue found evidence to support the interventions for compassion fatigue can help, but they also think that more studies need to be done. Burnout and compassion fatigue have not had a wide range of studies to support all the interventions that are a possibility. So many of the research did find that more studies need to be done. Von MOL et al. Assessed emotional distress experienced by healthcare providers, focusing on compassion fatigue, burnout, and preventative strategies. They recommended communication skills and mindfulness as a starting point for developing some interventions within organizations. Citrano et al. They focused on compassion satisfaction, burnout, and compassion fatigue. They found that staff required attention to time pressures, ergonomic conditions, trust, training, and meetings. They state addressing future insecurities is vital for addressing compassion, satisfaction, and burnout. They concluded that the frontline nurses are experiencing fear and burnout as a result of COVID. They state interventions within organizations will improve staff members' mental health by building self-efficacy and resiliency. COVID-19 and burnout. Hugh et al. Examined the mental health of frontline nurses in Wuhan, China. They examining fear, depression, anxiety, and burnout. Morganti et al. Found that burnout during COVID was prevalent due to high job stress, increased workload, limited organizational support, and time pressures. Talley affirmed that there is reliable and valid evidence for investigating depression, anxiety, and stress among healthcare workers that were working with COVID. Burnout and patient satisfaction. Rodriguez et al. States that burnout can result in significant patient vulnerability and unsafe care. Garcia et al. Examined burnout and patient safety relationships. They conclude that higher burnout levels are associated with worsening patient safety. And Dua et al. States that future studies need to be done, focusing on burnout interventions as it relates to patient safety and satisfaction. Burnout and satisfaction. Copanisto, Fotis, and Bologna found that nurses who perceive work environment as good and have lower amount of burnout. And it is also associated that higher quality of care is correlated with the perception of good work environment. West et al. States that burnout results in lower patient satisfaction, lower recovery times, lower quality care, and increase of medical errors. This is due to nurses being exhausted, both physically and mentally. They're at a higher risk of making those medical errors. Again, Ostopoulos et al. Looked at physician burnout and patient satisfaction. They also found that satisfaction was a direct correlation between physician depersonalization and emotional exhaustion. For my project, I chose the quality health outcome model as my theoretical framework. I chose this because it shows an association between the context, employee characteristics, interventions, and patient outcomes. It argues that the quality of care is essential for positive patient outcomes and patient satisfaction. The aspects of the care in this model are structure, process, and outcomes. As this project moves forward, due to limited time, I assessed the level of burnout in our facility on one of the floors. However, we do plan on taking this to the next step, and that would be implementing interventions and looking at our HCAP scores and seeing how those correlate as our levels of burnout decrease, do our HCAP scores go increase. So at that point is when our quality health outcome model will play more of a significant role. So it says the three aspects of care in this model are structure, process, and outcomes. As this project moves forward, interventions will be implemented. Future studies can be used using this model and examining how the burnout scores are correlated with higher patient satisfaction rates. There are several burnout studies or surveys that are available out there. I narrowed it down to two. The first one was the Maslow Burnout Survey. They have three subscales of emotional exhaustion, depersonalization, and personal accomplishment. I didn't choose this burnout survey for two reasons. One, it does have some criticism, as many of the questions are worded in a negative way. And there was some discrepancy on personal accomplishment. Not many people agree that that should be in there. As a spiral from the Maslow Burnout Survey, Oldenburg Burnout Inventory was created, and this was created so that it could overcome the criticisms of the Oldenburg Survey. This has been proven to be just as effective as Maslow and has been adapted to use for burnout inventories. So the Maslow Burnout Survey the Oldenburg Burnout Survey consists of 16 questions. 8 of those measure exhaustion and 8 of those measure disengagement. Some intervention strategies for research that I found was CURE states that prevention of burnout is key. That's the most optimal way, but unfortunately many of us are already experiencing burnout. So at this point, the earlier we can identify this, the better it will be for our outcomes. He states that prevention is doable if we have an awareness. So we need to educate our staff on what burnout is and our leaders on symptoms to look for. That way we can identify them early on. Kim et al. Looked at factors associated with burnout in healthcare workers. They concluded that a team environment and enhancing the supervisory roles can decrease burnout. Gavidan et al. Explored organizational management on burnout. They proposed the use of appropriate policies and programs for mental and physical health of staff. And Arkinson et al. And Zhang et al. Concluded that self-care, mindfulness, and communication interventions significantly reduce burnout. For my project design, I invited our nurses that are working in our COVID units via email. They were given an informed consent and they were given the Oldenburg survey with that. The project took place at Redlands Community Hospital. It was registered nurses that worked on the designated COVID-19 unit. We had one unit in our facility that we closed down to streamline all of our patients there. Nurses must have had 1 year of experience and been an employee of RCH or Redlands Community Hospital for a minimum of 6 months. For the materials, I used the Oldenburg survey. I used Outlook email so that I could get in contact with the nurses and invite them. I also left printed handouts in the nurses station for them to have easier access to it so they didn't have to print out the survey and the informed consent. For limitations, due to what this survey is, some nurses may fear that admitting to them having burnout and answering the questions that way, they might not want us to know that they have burnout up there. So we have to assume the nurses were honest, but we don't know. Again, fear of admitting that they have burnout. The low sample size was a limitation and the time restraint was a limitation. For ethical insurance, all employees were asked to voluntarily participate. They were aware that they did not have to participate. They were given an informed consent and all the survey results were kept confidential. Once they turned in their slip went into a folder and that was kept locked up in a safe room. So evaluation. So 54% of our nurses from our COVID unit participated in the survey. 3 of those were male and 22 of those were female. Majority of them had 15 of them had 1 to 5 years experience. 7 had 6 to 10, 11 to 20 years, 2 nurses had, and we had 1 nurse that had 20 to 30 years of experience. So these are the questions that all the nurses were asked. The ones highlighted in green are disengagement, and the ones that are in white they measure the emotional exhaustion. If you look at the scores, it was scored using a 4-point Likert scale from strongly agree to strongly disagree. There was a standard deviation of 0.52 that was used to identify what scores fell into the low range, the moderate range, and the high range. Some of these results from these questions were concerning, and we did intend to find some nurses that were definitely feeling burnout. 44% of our nurses agreed that they need more time now than in the past to relax and feel better. So therefore they are emotionally exhausted. 88% agreed that they think less about their job and they do their job mechanically. That can be very significant for disengagement. 48% that feel that they were emotionally drained. And one of the most worrisome ones that we found was 92% felt sickened by their work tasks. So that was a big finding there. I further broke this down to see if the years of experience correlated with the levels of burnout. In this particular project, 11 to 20 years of experience did have the most or the highest level of burnout. However, I did only have 1 person in that category. So I would say that 20 to 30 years of experience is a better, I can't think of the word, better represents burnout and its relation of experience. We thought that the less experience would have higher levels of burnout because they weren't used to working in that kind of level of stress. But what we found was the opposite, is that the more years of experience, the tired they were. I also looked to see if age had an effect. Again, 30 to 39 years seemed to have the most effect, as the other one only had, I think, 1 of a higher age year. Okay, so these are the results for our disengagement scores. The green line represents the moderate or mean. Anything below that green line is a very low rating. Anything between the green and the red is a moderate to moderate high, and anything above the red is a high risk rating. As you can see, all the nurses, most of them scored in the moderate to moderate high level for disengagement. Disengagement, I have not told you, can be defined as distance from one's work. So we don't want our nurses to feel disengaged. We want them to engage. If they're not engaged, they're not going to have, the empathy, the work ethics, and integrity that comes with doing our job. Exhaustion scores, again, the green represents below the green is low, moderate to moderate high is between, and then high is above the red. For this particular scoring, most of our nurses, or a good majority of our nurses, did score in above the high risk level, and the ones below that, many of those scored more towards the moderate to high risk level. So again, this is also a concerning finding, something that does need to be addressed on how do we get our nurses to practice some self-care and to regain their energy to come back to work. Implications. Nursing, there's many occupational threats in nursing because we have demanding roles. They have a risk of contracting diseases. There's limited leadership support or the perception of, and there can be some interpersonal job conflicts. All of these lead to burnout, and they stem from disengagement and exhaustion. Recommendation. As stated earlier in my literature review, awareness is very important. I recommend that we train all of the leaders and staff members on what burnout is. Let them know it's okay to experience burnout. It's normal, especially given what we just went through, and help them to identify if they are having any of these symptoms themselves. Resilience training has been shown to be one of the strongest interventions for burnout. Resilience helps build our own selves from within. It's mindfulness, yoga, meditation. These trainings help us turn our negative energy into positive into positive energy. So I recommend that we do train the staff on what resilience training is and highly encourage them to get involved in outside activities that allow them to rest and refocus. Shared governance has been linked to increasing nurse engagement. Nurses want to have a voice, they want to have a word on policies and changes and things that are occurring. So if we have a shared governance among the organization, they feel more involved and it keeps them more engaged, and many times they end up staying longer as employees. Schedule and reducing non-clinical staff. Schedule can be tricky. Sometimes we don't have control of who's calling off or people who are going to leave the organization, but it's important for us to look ahead and do our due diligence in getting our schedules, our staffing where it needs to be so that we have adequate support. We have a resource nurse so our nurses can have breaks on time and they can go to lunch on time. And if they need that support person, it's there. When you're short staffed, you have to take on more patients, and it just makes for job dissatisfaction. It makes you more exhausted and less engaged. Reducing non-clinical tasks. It's been found that some of the tasks that we ask nurses to do are non-clinical. So I suggest that we look at what we are asking the nurses to do, examine it, and see if any of those tasks can be taken off of their plate and maybe put somewhere else. And then lastly, I recommend that we expand the survey. We did do a small portion of the hospital, but burnout's being felt among everybody in the organization. And just because they were on the COVID unit who were surveyed doesn't mean that the rest of the hospital did not have effects of COVID as well. So I do recommend that we expand the survey And that is a plan going forward within the organization. And that completes my presentation. Thank you for attending. And do you have any questions?
Thank you, Lisa. So at this time, we'll go ahead and open up the floor for some questions or comments.
Hi, Lisa. Susan Trell. I found your presentation to be really, really timely. How interesting the statistics that you bring us. Wow. I think you said 67 or close to that, some percent of nurses feeling like they're not coming back, or they'll leave the facility or maybe leave our profession. That
Yes.
to me is just it's astounding. And so how interesting to see some work done in this area post-COVID, because we're not that far post-COVID, are we?
No.
Yeah. Are your units full? Are they tailing off? Are they not busy? How are they now?
No, I think we only have 1 or 2 admits at this point. Our COVID unit has actually now been closed down.
Okay, that's good.
Been reopened for normal yet, just in case.
Yeah.
Especially with the new virus coming around. So yeah, but
Well,
our numbers are very, very low now.
Your slide presentation I thought was beautiful, really nicely done, not overdone in text, beautiful graphics. So that was very pleasurable to look at. I'm curious about how you as a leader plan to now implement the interventions, and which area of that are you going to try to prioritize as the first 1 or 2?
So as a leader, I think the first and most important thing is to bring awareness to our staff, because some staff don't even know that they're having burnout. They may just feel tired, but they don't understand how to treat it. And you can't even treat your burnout symptoms if you don't know that you're having it.
That's right.
So I think the most important thing is bringing awareness to the staff, and letting them know that there are interventions that can be implemented to help them overcome this. In fact, I did present this at our professional practice council meeting last week, and one of the managers shared with me that one of her staff members is actually suffering symptoms of PTSD. Anytime a ventilator alarm goes off, it freaks her out and just brings back horrific feelings for her.
Yeah.
And I think that's just the beginning. So again, we need to bring awareness to our staff members so they understand that they're not the only ones going through it. It's okay. And we just need to help you get through it.
So once they're aware, where do you see yourself taking this? What would be like your next big thing you would like to do?
So we have some collaborative meetings going on for interventions. This just happened to come at a time where we are coming out of COVID, and now a lot of the unit managers want to proceed forward with looking into how do we help our staff. So we haven't had solid interventions yet, but we have, we just got 2 Caritas coaches that are now certified Caritas coaches who did a presentation on wellness and mindfulness, and offered their services in going up and speaking with them. And one of them plays beautiful music and offered her services of playing music. We talked about, doing like Thankful Tuesdays and just giving recognition to people, and just, trying to incentivize somehow and just bring some joy back into our units,
I love the idea of the music. You could set up like a baby grand right by the nurses station. That would benefit everybody, right?
She's done it for the ER staff throughout.
I love that idea. So do you think your facility will throw any money behind this to help you, do some things for your staff?
I don't know yet. That's baby stages.
I don't know. Sometimes just bringing donuts and passing them out and have, I don't know.
Typically the managers or the directors will do that. It's not normally an organizational supported thing. So yes, I do know many floors are intending to do that, but I don't think it's going to be backed by organization. It'll be more of an individual basis.
Yeah, I'd love to see your organizational leadership get on board with the problem. I think if they were as aware of this as you've presented to us today and all, if they were really aware of this, you'd think
Yeah.
they'd get on board and try to
I
help.
do believe they are. We did
Yeah.
start a peer support team that is with our chaplain and social services.
Mhm.
And that meets once a month, I believe, or once every 2 weeks. I can't remember. But that is a peer support team. So they are making attempts. Just nothing has been made in concrete yet. But
Yeah.
the awareness is there that
Mhm.
we do have an issue. More so on some units than others. I would say our critical care director manager and our ER director manager are feeling most of the effects of it. So they very much are ready to go and get some things done.
That's great. Well, I think this has been a very timely and appropriate and important issue to address. And so I thoroughly enjoyed it. Thank you, Lisa. Well done.
And I second everything that Susan just said. You know, one of my concerns as we move out of this, and clearly, you know, at this point in time, we're moving out of it, right? We've got good vaccinations responses, and we have states that are reporting 0 deaths for a day for the first time since all of this started. And is that then they'll just say, okay, it's over, go back to your norm, right? Well, that's the thing behind trauma, is that you don't go back to the norm. It didn't work for us when our soldiers came home, and it's not going to work for us for our bedside soldiers either. Now, I will say that Gloria and I have a thing for therapy cats, so you know, you could recognize some of that. But assuming that you're not going to get large sums of dollars behind this, having spent a lifetime in healthcare, I like, you know, your ideas for even just some smaller things, not necessarily always around donuts, because that's how some of us got to be the way we were, because we got fed donuts every time we turned around, and all the patients' families bring chocolates. And, but just doing something, bringing in a, you know, therapy dog or a therapy pony and say, you know, this is to help you, that makes it clear to those nurses that somebody's concerned about them. That, I mean, it may be a small thing, right? But it doesn't cost any money. And all of those kinds of things added together at least provide a culture of, you know, we know what you've been through, and we want to be here for you, kind of a thing. I personally think anybody that had to work a COVID floor should get 2 weeks paid vacation in Hawaii on a beach. You know, that might help. But there are also resources. I know when we had bad codes in the ER, they'd bring a professional in to, you know, sort of debrief and allow people a time to, you know, talk or share or whatever they needed to do. As far as your presentation goes, you had me at standard deviation. Yeah, I was like, oh, we did some statistics. That's awesome. Just awesome. So like I said, I second everything that Susan said. Your slides were good. You covered the important points. Are you gonna take this on the road internally at least?
So the idea is that we will be expanding it. We will be doing the burnout survey on many of the other units, and like I said, implementing the interventions, and then resurveying in about 6 months to see if we have seen any changes, and then also comparing it with where our patient scores now and where will they be then.
Yeah, it wouldn't take a whole lot, and I think you could actually put this in one of the nursing journals, you know, the ones that don't require, you know, actual research and 10,000 pages of references. You know, it certainly is article quality, and it's timely, right?
Yes, very timely.
Good
And
job.
there needs to be more research really does need to be coming, because you know we're only feeling the early stages of the after effects, and you know it's only going to increase, I'm sure.
Yeah, yeah. Good job.
Thank you.
Susan asked all of my questions, so I don't have anything. So thanks. Great presentation.
Thank you.
Okay, thank you, Lisa, for your presentation. And as I said, I'll be getting back with you probably sometime this afternoon.
Okay.
And at this time, we're going to go ahead and ask you to leave, and we'll be discussing your presentation. And
Okay.
good job, Lisa. Good job.
Make her give you back the host, or
I think I can turn off the
you need-
recording myself.
Thank